Good evening, everyone, and welcome to Singapore Cancer Society No Cancer to Beat Cancer Women Cancer Webinar 2021. My name is Ivy Lim. I'm your host this evening, and welcome everyone. Singapore Cancer Society, also known as SCS, is a community-based voluntary welfare organization dedicated to educate the community on cancer, maximizing lives. It provides patient care services to needy cancer patients through its welfare, hospice home care, cancer treatment subsidy, and rehabilitation support program. In addition, the Singapore Cancer Society also provides $25 funding assistance for mammogram screening, cancer screening services for colorectal and cervical cancer at no charge at Singapore Cancer Society Clinic at Bishan. For more details, please visit Singapore Cancer Society website or call 1-800-727-3333. If you have any questions related to this evening's webinar, please remember to submit your questions through the Q&A function at the bottom, the middle key button you see that says Q&A. We will try our very best to answer them as many as possible. And this evening, we are very, very happy and very, very honored. We have three doctors with us. Introducing to you, first doctor is Dr. Wong Wai Lung. He is the head and senior consultant from the Department of Gynecological Oncology from the KK Women and Children Hospital. And we have Dr. Tan Chuan Chen, the head and senior consultant from the Breast and Endocrine Surgery from Ng Teng Fong General Hospital. Dr. Si Hui Ti, our senior consultant for medical oncology from Parkway Cancer Center. We'll be starting shortly our Known Cancer to Beat Cancer Women Cancer Webinar 2021 shortly. Welcoming our first speaker, Dr. Tan Chuan Chen. Dr. Tan will be talking to us about breast cancer. Over to you, Dr. Tan.
Thank you, Ivy. Good evening, everyone. My name is Dr. Tan. I'm a breast surgeon. And tonight I'm going to talk about breast cancer. And it's just following the same theme as all my other speakers, knowing cancer to beat cancer. The reason why we do this is so we understand the basics of breast cancer, and then we know how we can combat this dreadful disease. So first, these are my disclosures. So I think I'll start from the very basic. What exactly is cancer? So the American Cancer Society talks about cancer or describes cancer as a group of diseases that's characterized by two things. Number one is characterized by cells that are mutated and abnormal. And the second thing is that these cells grow uncontrollably. We have no control over how these cells grow. And if you look at this slide on the left-hand side, there's the picture of a normal cell. And the one on the right-hand side is a picture of an abnormal cell. As you can see, abnormal cells look very ugly looking. They just look really abnormal. And that's how we diagnose them. We look at it and it looks abnormal as well. And the question a lot of patients ask me is, what do cells do normally in every day to day? And so what cells do is that they grow, they multiply and divide. And the reason for doing that is for renewal and for growth. And that's what happens in our body every day. Most cells do that. But the key here is that most cells, when they grow and they renew, the renewal is very tightly controlled by our body. Our body tells them exactly how much to renew, how much to grow, and when to do it. The problem with cancer cells is that because they're so mutated and abnormal, the body has no control of it. So they continue to grow and grow and grow, and eventually they form a little lump or mass. And after some time, they accumulate more mutations. And over time, they then gain this ability because of the mutations to spread to another organ or invade adjacent tissue. And that's when we diagnose it as cancer. For what about breast cancer? For breast cancer, it's very similar. Breast cancer begins life as a normal breast cell in the body, and it then accumulates a certain mutation in its DNA, usually by chance, and then this allows it to grow unchecked. Basically, the body has no control over it. As it grows, it forms a little mass as before. It forms a little lump, and sometimes that can be felt. And over time, as it gains more mutations, it then gains that ability to spread. And that's where we define it as breast cancer. So how common is this disease? Breast cancer, unfortunately, is not uncommon. In most Western countries, about 1 in 8 women would be diagnosed with breast cancer sometime in their life. And most of these women are above 50 years of age. How about Singapore? Unfortunately, in Singapore, it's also not uncommon. About 1 in 10 to 1 in 13 women in Singapore would develop breast cancer in their life. I've shown some of this table and graph on the slides, and this is from the Singapore Cancer Registry. As you can see, breast cancer is the most common cancer among Singaporean women, and it's the most common cancer causing cancer death among Singaporean women. The lower slide shows it in a graphical representation and on the incidence of breast cancer among Singaporean women. I can see it's by far a mile ahead of the second cancer, which is colon and rectal cancer. So it's something that important that we as a community and society deal with. The important thing though is that even though breast cancer is common, but it's a very treatable disease. It's something that's very treatable when found early. This is a graph of a 5-year survival for breast cancer among the different countries for patients in different countries. And as you can see, the 5-year survival for Singaporean patients are 80% 5-year survival. Now, 5-year survival is a concept used by cancer specialists. And what it does is that it measures the outcome of patients who have a certain disease. And the purpose of that is to tell us that how well it responds to a treatment that we have, as well as how good our measures, our preventive measures, or our strategies in trying to reduce this rate. And you can see Singapore does pretty well. So what that tells us is that if we find it early, we can treat it very well. Stage 1 breast cancer, which is a very early stage breast cancer, has in excess of 95% 5-year survival. So what are some of these strategies we can do to combat this disease? Firstly, early detection saves lives. What that means that if we catch this disease early, it's a very treatable disease. It has a very good survival, meaning that patients are unlikely to die from this disease. Secondly, the treatment at an early stage is much simpler, cheaper, and much less complex. So how do we then detect this disease early? Well, there are 2 ways to do it. The first way is through mammographic screening, and the second way is through what I call breast self-awareness. What breast self-awareness is basically that we educate women to be aware of what's normal in their body, and then to understand what are normal signs and symptoms of breast cancer, so that when they look at and check their own body, they can then be aware and detect these abnormalities very early on, and then seek medical help early. On the left-hand side of my slides, you can see that it's also a slide teaching how to do breast self-examination. Breast self-examination is something important to be done. I advise my patients to check their breasts regularly every month. The best time probably about half a week to a week after their menses, because that's the time where the breast is least tender and least swollen. I know it's difficult. A lot of patients tell me it's a difficult thing. The Singapore Cancer Study came out with a campaign 2 years ago to teach women how to do this through a cartoon character called Auntie Sue, and we can access this through the SCS website. But the simplest thing I tell my patients that if you don't know how to do it, the next time you see your local doctor, your GP for anything, just talk to them and ask them to teach you how to do it. And that's probably the best and simplest way to learn how to do it. It's actually something quite simple. The other strategy is to do regular mammographic screening. And what that means is to do a mammogram of the breast regularly. And we know that the reason we do this is because we want to catch the cancers early at a stage where it's not even detectable and there are no signs and symptoms. And we know that if we do that, for patients who participate in this sort of screening programs, the chance of dying from cancer, the likelihood of dying from cancer is reduced by 20 to 40%. So we know it's effective. In Singapore, the screening guidelines are once every 2 years for women above 50, and yearly for women from 40 to 50 years old. And they are for asymptomatic women, meaning that if women don't have symptoms, they should still participate in this screening program. Now, mammogram screening is not dangerous. It has very low risk of radiation, but unfortunately, compressing the breast during mammogram screening is necessary. The reason we do that is because the compression holds the breast together so that when they take a X-ray picture of the breast, it doesn't move, and so there's less artifact, as well as it flattens the tissue, so it allows a better picture for the radiologist to read. A lot of my patients tell me that it is quite uncomfortable, but what I usually advise them that there's certain strategies you can do to try and reduce this discomfort. You could take a Panadol 3 or 4 hours before that, or time the screening at times where it is where it is after your menses, half a week after menses, where again the breast is at least swollen and tender. So those are some strategies that can be done to minimize the effect, the discomfort from this. The third strategy I'd like to discuss about is knowing your own risk for breast cancer. Now, a lot of patients ask me why did they get breast cancer? And the what I tell them is that we don't know exactly why a woman gets breast cancer, but we know that it's probably due to a combination of nature and nurture. Nature being the genes we are born with, and nurture being how we brought up and the lifestyle that we lead. And all these factors influences the likelihood or chance of a woman to develop breast cancer in their life. And these factors are known as risk factors. Risk factors can be divided into modifiable ones and non-modifiable ones. Non-modifiable ones are things that we cannot change. We cannot change who we are born to. We cannot choose our parents. We cannot choose our gender. So those are things we cannot change. But modifiable risk factors are things that we can change. For instance, our diet, alcohol use, smoking, exercise. Those are things that we can change to lead healthier lives so that we can reduce the chance of developing breast cancer. Now, knowing your risk goes beyond just lifestyle modification. It's about empowering women to know what their risk is of getting breast cancer. Now, if I were to know that I was a higher risk than an average person for getting breast cancer, that I'll, number one, be more compliant to doing my screening, check myself more regularly, as well as talk to my doctor to see whether there are any other ways, any supplementary type screening that may be more effective. So knowing your risk is an important strategy to empower yourself. We know that the four biggest influence of risk to breast cancer is age, gender, so being female, being a woman increases the risk of breast cancer more than a man, family history, and breast density. So just in summary, the three strategies that we have to combat this disease is being aware of your own breast and do regular breast self-examination, doing regular mammographic screening, and knowing your own risks. Mammographic screening can be done very cheaply and very accessible in Singapore. All government polyclinics are run by Breast Screen Singapore, and they do mammographic screening. I know the SCS clinic at Bishan also has that. But the simplest thing is to either talk to your breast surgeon or your local GP and to arrange that. I would like to end with the graph at the bottom slide. And basically that's again by the Singapore Cancer Registry. It's data on women who presents with breast cancer in Singapore and what stages they are, the proportion of them at which stage. And unfortunately, as you can see, still about 10% of women present at a very late stage, at an advanced terminal stage, stage 4 breast cancer, and which is a bit unfortunate because Singapore is a first world country, is very accessible and affordable world-class healthcare system, and I think that it's important that as a society we advocate that this for women's health, and I think it's not just good enough for us to know this, but it's for us to share this message with our mothers, sisters, and aunties. Thank you.
Thank you. Thank you, Dr. Tan. Thank you very much. We will be answering the questions at the end of the talk by all the three doctors. So please keep your questions coming. And also some of your questions has been answered through the slides and through the talk. So do look into them. And if we don't answer the questions specifically during the Q&A, it's because they have been covered by the slides. We'll do our very best to answer as many questions as we can. Following up, we are inviting Dr. Wong Wai Luk, the head and senior consultant from the Department of Gynecological Oncology from KK Women and Children Hospital to talk about cervical cancer. Over to you, Dr. Wong.
Okay, thank you, Ivy. Good evening to the audience. I would first like to thank Singapore Cancer Society for inviting me to this this year's webinar on No Cancer to Beat Cancer. So today you're going to learn how to beat cervical cancer. In fact, I'm going to tell you how we can eradicate cervical cancer from Singapore. So let's start with anatomy. Where is the cervix in relation to the female reproductive system? So the female reproductive system is composed of the uterus, both fallopian tubes and both ovaries. And the cervix sits at the entrance to the womb or to the uterus. So it is actually a gateway to the uterus, and it is important because it helps hold the pregnancy till term. And so that's where the cervix is. And today, my talk is concentrating on cervical disease and cervical cancer. So how do one get cervical cancer or cervical disease? It all starts with this small little virus called HPV, or human papilloma virus. Now, there are many strains of HPV. It's like the common cold, There are more than 200 strains of HPV, and HPV is divided into high risk and low risk. And examples of high risk HPV is type 16, type 18, 31, 33, etc. And the examples of low risk HPV are types 6, 11, 42, 44, etc. Now, we only need to concern ourselves with regards to cervical cancer to the high risk HPV, because type 16 and 18 contributes to 70% of cervical cancers. The low risk HPV doesn't cause cervical cancer, but they will cause things like genital warts. So it is the high risk HPV which we are most concerned about. So how does one actually get infected with HPV? HPV is transmitted through sexual intercourse, and it can be a vaginal route, anal route, or oral route. It really doesn't have to be penetrative sexual intercourse for one to get HPV. Heavy petting can also transmit the human papilloma virus. So how does HPV actually cause cervical cancer? And if you can see in this diagram, this is the view of the cells in the cervix. Now, HPV, once it infects the cells of the cervix, it undergoes a variety of changes and is classified into low-grade change, and then to high-grade change, and then to cancerous change. And the precancerous changes in the cervix is termed as CIN. It can take 5 to 20 years before a precancerous change can actually turn cancerous. So hence the importance of screening for cervical cancer, because you have this huge lag time before any of this precancerous change actually turns cancerous. So once, if there are abnormal cells detected on the pap smear, or if HPV is detected through cervical cancer screening, then the woman will be invited to a colposcopy clinic. And what a colposcopy clinic does is it visualizes the cervix by using a magnifying glass or magnifying camera, I would say. So some solutions are placed on the cervix or applied to the cervix to amplify the abnormal areas. And you can see from the diagram that, you can see the amplification of abnormal areas, the low-grade change to high-grade change, and hopefully not cancerous change. Now, if there are changes that are seen on the colposcopy or through the camera, then a pinch of tissue or biopsy is taken to confirm the change. Now, the good thing is that precancerous change is highly, highly treatable. You can either excise or cut out the area, or you can burn the area. So examples of how we can cut out the area, we can use a LEAP procedure. That is basically using a hot wire to just cut out a piece of or a larger chunk of the cervix, the abnormal areas. You can cut it out using a laser, or you can cut it out using a knife. You can also ablate it. Ablate it means to burn it off, either using laser or cold coagulation. The choice of treatment really depends on the woman's fertility wishes, and that you have to discuss with your doctor on the appropriate and choice of treatment, whether to excise or whether to ablate. So screening for cervical cancer, we in Singapore, we have national guidelines for screening, and it has been launched in 2004. And it has recently been updated in 2019 in light of recent evidence. So here it goes. From the age of 25 to 29, for those women who have had sex before or sexual intercourse before, it is advised to have a pap smear every 3 years. And from 30 years old to 69, again, for those who have had sex before, a HPV test is done every 5 years. Now, the reason why we chose, or the society actually chose to do HPV test from 30 to 69 rather than to start from 25 is because HPV is very common in the 25 to 29 years of age group, and that will lead to a lot of investigations. Now, having said that, even if HPV is very common, it is the persistence of infection that actually causes problems rather than an acute infection. So I'll come back to that soon. So how a pap smear is done and how HPV is tested, it is essentially the same method. A speculum is inserted into the vagina, the cervix is visualized, and a brush is used to sort of scrape some of the cells off the surface of the cervix and sent to the lab. So pap smear and HPV test is done in the same way. The advantage of HPV is that it can be self-collected. The woman can actually collect the HPV sample in the comfort of her own home or in the toilet of the clinic, but the results will still have to be sent to the lab for analysis. So now I'm going to touch on cervical cancer. And it's important to know that, again, there's a very, very long period for women to actually develop cervical cancer. Hopefully you don't develop cervical cancer, but if you do get infected with HPV, and if the HPV stays in the system long enough, it starts to cause changes to the cells, from low-grade change to high-grade change to cervical cancer. And this can take, many, many years. So cervical cancer, unfortunately, it is still the second most common female cancer in the world. And the reason why cervical cancer is so common in the developing world is because of education, and also of they don't go for screening for cervical cancer. Now, in Singapore, unfortunately, it is still the 10th most common cancer in Singapore. Even in our developed nation, cervical cancer still remains the top 10 female cancers. So I hope that in the next few years, we will not see it in the top 10 cancers for women anymore. So the risk factors for cervical cancer is actually any behavior or anybody who has an increased exposure to HPV or human papillomavirus. And this will include early onset of sexual activity, multiple sexual partners, people of low socioeconomic status. Smoking actually lowers one's immunity. So if you do get the HPV, it is very difficult to clear the HPV if you are a smoker. Hence, smoking is a risk factor for cervical cancer. Now, taking oral contraceptive pills is really not a direct association with cervical cancer, but it has been studied that people or women who take oral contraceptive pills tend to not protect themselves when having sexual intercourse, hence increasing their exposure to HPV and hence increasing the risk of cervical cancer. Now, HPV is a virus, you need your own immunity to clear this virus. And if you have any conditions that actually suppresses one's immunity, such as having HIV infection or taking any immunosuppressants, such as steroids for autoimmune diseases, that can lead to increased risk of cervical cancers as well. And because you are unable to clear the HPV on your own. Now, HPV is very, very common. 80% of women will get HPV at one point in time of their lives. But the good thing is that 90% of women will clear the infection within 2 years because of their own immunity. There is no magic pill that you can take to actually clear the HPV. It is your own body's immunity. So HPV accounts for more than 99% of cervical cancers. And again, I cannot emphasize this enough. It is not an acute infection that causes cervical cancer, but a long-term chronic infection which you cannot clear. And it takes many, many years for this infection to turn cancerous. It will cause the cervix to change from a low-grade change to a high-grade change, and it can take up to 20 years before it turns cancerous. Hence, the importance of screening. It is still very highly treatable at the pre-cancer stage. So it is really no excuse for anyone to get cervical cancer. So what are the symptoms of cervical cancer? Obviously, if you have a cervical cancer, there is a growth at the cervix, and this can cause irregular or heavy vaginal bleeding. There could also be bleeding after sexual intercourse because of trauma to that area, and copious vaginal discharge. Now, depending on the stage of cervical cancer and how big it is and whether it has spread, it can cause pelvic pain, can cause lower back pain. If it is large enough, it can actually compress the rectum and cause constipation, or eat into or compress the bladder, which is in front of the cervix, and cause frequency or being unable to pass urine or even blood in your urine. So how do we diagnose cervical cancer? Now, cancer is always diagnosed with some form of tissue. So a piece of tissue is always sent to the lab to confirm the presence of cancer. And then we go on to stage cervical cancer. And staging of cervical cancer is basically finding where the cervical cancer has spread through. And it is done through a variety of scans, an MRI scan, a CT scan, or even a PET CT. So why is stage so important? Because stage tells the doctor and the patient where the disease has spread to. And it also tells the doctor or the patient the prognosis of this disease, and more importantly, how to treat this stage of cervical cancer. Now, cervical cancer can be treated. Very early cervical cancer can be treated via surgery. Either a cone biopsy meaning taking a big chunk of tissue together with the cancer, or doing a radical hysterectomy, meaning to take the uterus, the cervix, obviously, tissues around the cervix, which is known as a perimetrium, and a cuff of the vagina and the lymph nodes. So these are the surgical options for early stage cervical cancers. Other forms of treatment will be chemotherapy and radiotherapy. It can be, and most of the time, it's a combination of both. Unfortunately, for late stage cervical cancer, it will be a combination of chemotherapy and radiotherapy. So the WHO, or World Health Organization, has a very bold vision. They say that no woman should die from cervical cancer. They have set some targets which should be met by the year 2030, and these are known as the 90-70-90 targets. So they state that 90% of girls should be fully vaccinated with HPV vaccine by the age of 15. 70% of women should be screened with a high performance test by 35 years and again at 45 years of age. And 90% of women identified with cervical disease will receive treatment. So this is the WHO vision for women, which has been published recently. So how do we prevent cervical cancer? First thing is to get vaccinated, right? We have few HPV vaccines in Singapore. There are 3 types of vaccine, and it's already part of our national vaccination program. So from age 9 to 14 years old, only 2 doses are required. And from 15 to 25 or 26 years old, 3 doses are required. Now, depending on the type of HPV vaccine, some are MediSafe claimable. Besides vaccinating yourself or protecting yourself against getting this HPV infection, for those who are sexually active, you also need to screen for cervical disease. And a pap smear, as I alluded to earlier, is recommended for those who are sexually active from the age of 25 to 29, and a HPV test from 30 years old onwards. And now HPV test is done every 5 years. A pap smear is done every 3 years. So even if you are HPV vaccinated, you should still go for your cervical cancer screening, provided you are sexually active. So in summary, cervical cancer is preventable, is so preventable. Get yourself vaccinated with a HPV vaccine. Go for your regular screening, pap smear, or HPV test, and of course, early presentation. I will state again what WHO has stated, that no woman should die from cervical cancer. So thank you.
Thank you, Dr. Wong. Thank you very much. I like the tagline, or rather what WHO has said, no woman should die from cervical cancer, is truly preventable and is with vaccines and regular checks. Inviting to speak next is Dr. C. Hui Ti. Dr. C will be talking about uterine cancer and ovarian cancer. Over to you, Dr. C.
Thank you very much, Ivy, and thank you, Chan Chen and Wai Long. Unfortunately, I've been given the task of giving the final talk to two very, very well done talks on cervical cancer and breast cancer, both of which can be screened at an early stage, and therefore the chances of cure is extremely high. And of course, I reiterate at this point in time, cervical cancer is, I would say, at large 90% preventable. Unfortunately, for ovarian cancer and endometrial cancer, as you can see from the two graphs here, it is on the rise in Singapore, as with any other places in the world. These two are largely not screenable for the general population. The only individuals that we invite for screening are ladies who have a very high family history, a very strong family history of ovarian cancer and or endometrial cancer and colon cancer, and I will elaborate on that. So the first take-home message is ovarian cancer and endometrial cancer for the general population has no screening technique. But like any other cancers, which can be slow growing or fast growing, it goes through a precancerous stage that can take up to 5 to 10 years, where there's signal control cell division mistakes and programmed cell deaths that are not going to happen, and that leads to tumor progression, uncontrolled cellular proliferation, leading to tumor growth and metastases. So when we talk about cancer on the whole, majority of people would ask us, what is the cause of ovarian cancer, endometrial cancer, cervical cancer? Now for ovarian cancer, endometrial cancer, breast cancer, colon cancer, many of the cancers that we face, it is due to part of it, our own lifestyle changes, and I'll share a little bit later. So the trends in gynecologic cancers, many years ago, the female breast used to be thought to be a gynecologic organ since it's got to do with lactation. So breast cancer is right at the top, which Dr. Tan has already expounded very clearly how to detect it early and how to treat it. Next down to uterine and ovarian cancer. Uterine is number 4, ovarian is number 5, and cervix is right down there at number 10. And very soon we hope and we pray that it will be below number 10 and it will no longer be paid attention to, although again, we say it is one of the most preventable. So looking at the graph on the right, these are the trends in the last 20 years. The red line is the trends of cervical cancer going all the way down, the trends of ovarian cancer going up, and the trends of uterine cancer going up. And of course, uterine cancer in the very recent years has overtaken that of ovarian cancer. So endometrial cancer to begin with, let's look at the risk factors. We look at some of the risk factors here: early menarche, which is having my menses early; nulliparity, meaning that I don't really have children; weight more than 175 pounds, the relative risk goes up to 7.2 times; body mass index of more than 29, diabetes, unopposed estrogen use, which is very rare nowadays since we don't really give hormone replacement therapy. Looking at that, actually, tamoxifen use, which is for breast cancer, is way lower than that of a weight that is high and a body mass index that is high. Increased parity, having many children, actually have a very, very small increased risk, and oral contraceptive pill actually have a minimal increase. And looking at diabetes, diabetes is not just associated with endometrial cancer, it is associated with many other cancers such as pancreatic cancer, colorectal cancer, and breast cancer in a postmenopausal state. So essentially, if we look at the relative risk here, the lack of children, a weight being high and a body mass index of more than 29 seems to be the highest risk. Although unopposed estrogenic use used to be more than 10 times or more than 9.5 times, it is a rare occasion that we give unopposed estrogenic use in hormone replacement therapy. But I hold that, and you need that to hold it in your mind, because there are, in estrogenic use, there is estrogen, there is given exogenously, meaning I take estrogen tablets in order to help with my postmenopausal symptoms. Again, I say that is something that is of the past now. And endogenous estrogen, which is estrogen that was produced by our own body, and that will be related to our lifestyle. But let's look at the signs and symptoms first. The signs and symptoms of endometrial or uterine cancer are postmenopausal bleeding, irregular menses, intramenstrual bleed, unusual and smelly discharge from the vagina, and in a very late stage back pain, pain upon urination, sexual intercourse, pain and bleeding upon defecation, which is rather unusual because by then a patient would have ignored the prolonged postmenopausal bleeding, the irregular menstrual bleeding, and the intramenstrual bleeding to lead to the stage whereby it leads to back pain and pain upon urination. So in fact, actually, endometrial cancer, most of the time is found at very early stage because postmenopausal bleeding is often alarming. And with that, a patient would usually seek for attention back to the gynecologist, and we find it at this early stage. The unusual finding, or sometimes we worry, is that ladies who are perimenopausal at the age of 45 to 55 continues to have very irregular menstrual bleeding. In fact, stops and starts. And when they seek a medical attention or they talk to their friends, people would just tell them, oh, no lah, this is just perimenopausal symptoms. Maybe it's very low and maybe it's very irregular because it's going to be the change in the years, never mind. But of course, if they sought a medical attention early on, a astute physician would have done some further investigations, ultrasounds, perhaps some blood tests, an endometrial biopsy to make sure that we were not missing a endometrial cancer. So is screening available? No, not really. No, it's not necessary as long as ladies understand and remember that the signs of postmenopausal bleeding and irregular menses requires immediate attention just to be sure. And therefore screening is only necessary for ladies with very high risk, such as that with a very strong family history of colorectal and endometrial cancer. So I'm just going to truncate the management of uterine cancer in the light of time to more of a synopsis than the details. For the management of the uterine cancer, first of all, of course, we have to diagnose it first by dilatation or curettage, or the office Pipel histological examination. The details aren't important on a webinar. The most important thing is if there is irregular bleeding, postmenopausal bleeding, or intermenstrual bleeding, then one should seek medical attention. An office Pipel histological examination can be done that is inexpensive. And if it requires a further confirmation, then a small day surgery with what we call a D&C, which is dilatation and curettage, to confirm the findings of the office Pipel or to confirm the findings of endometrial cancer. Once the diagnosis has been confirmed, a majority of ladies, if they had completed their family, would be recommended a total hysterectomy, meaning removal of the entire uterus and the cervix, bilateral sulfaceoophorectomy, which is removal of the ovaries. This is important because the lady is usually perimenopausal, and the removal of the ovaries would help us to stage the cancer. And if needed, a complete pelvic or periaortic lymph node dissection. That's somewhat controversial because we usually recommend that for younger ladies. For very elderly ladies in their 80s or 90s, sometimes we forego that for the risk of the complications from the surgery. But generally, if it was a young, fit lady below 50 years old, this will be a recommended surgery to ensure the accurate staging. So the majority of cancers are grade 1 or grade 2, with what we call myometrial invasion that's less than 50%, is cured just by good surgery alone. If it goes up into higher grade or if there is unusual histology such as uterine papillary serous, undifferentiated, all these are jargons, these ladies may benefit from post-surgical chemoradiation. Fortunately, prognosis is good in most, if not all cases, because majority of the ladies that we see are early stage and endometrioid, which is what we call garden variety uterine cancers. But some cancers need to be followed by adjuvant therapy with chemotherapy. And I share a little bit here. In the past, we used to just know that there is uterine cancer. We call it the type 1 or the type 2. The type 1 tends to be due to lifestyle issues, younger, a little bit bigger in size, unopposed estrogen, usually by the popularity of hormone replacement therapies in the 1980s, which results in a hyperplasia of the endometrial lining as a precursor, but it's usually confined to the uterus and has a very favorable outcome. Then we have this type 2, which is a bit more unusual, 15 to 20% of the time occurring in older ladies, usually quite slim not obese, and unrelated to unopposed estrogen. They tend to have these histologies called serous carcinoma, clear cell carcinoma, carcinosarcoma, or otherwise known as malignant mixed Müllerian tumor, undifferentiated or dedifferentiated carcinoma. Of course, now with the advent of molecular studies and molecular biology and molecular testing, we are able to divide the so-called type 1 and type 2 into molecular mutations to find the so-called targeted therapy and to be able to tell our patients whether their cancers are malignant, more malignant than the usual, more aggressive than the usual, or just a simple standard low-grade endometrioid carcinoma. So for patients with serous carcinoma, clear cell carcinoma, carcinosarcoma, unusual names that you may not have heard of, these ladies would be recommended adjuvant chemotherapy followed by radiation. So there are many guidelines as to guide the doctors to know what's the best treatment options. But I reiterate here that if we find the endometrial cancer at a very early stage, surgery and perhaps just a little bit of radiation would be more than enough. But sometimes if we had been slightly older, or if the tumor is a little bit more aggressive or slightly higher stages, patients would then be recommended systemic adjuvant therapy, radiotherapy, chemotherapy to reduce the risk of the cancer returning and therefore increasing the chance of cure. But nothing is compared to finding this cancer early. But because there is no screening technique for ladies of the population risk, meaning general risk and not one with higher family history, the main thing here is to be aware of the symptoms. If there is endometrial, if there is postmenopausal bleeding, intermenstrual bleeding, or irregular bleeding, please seek the attention of the gynecologist as soon as possible, just to be sure. So what about advanced uterine cancer? Often we have ladies who may have symptoms of early uterine cancer, and they say, never mind. I mean, nowadays the medicine is so advanced. Even if I find it at a later stage, I will be able to cure it because my doctor will be able to find so-called this targeted therapy for us. The fact is that uterine cancer treatment has come a very long way. It's taken us now almost 40 years to determine the benefits of adjuvant chemotherapy, the benefit of adjuvant radiotherapy, and what to do and what not to do for our patients. But in conjunction and in parallel with the findings of benefits of chemo and radiation, we're also coming up with the integrated genomic characterization of endometrial cancer. In fact, as early as 2016 or as late as 2016, there is a reclassification of some of the tumors based on molecular testing to tell us that some of these cancers really need not be treated. Even if it was very low grade, even if we were to wait upon it, it didn't need to be treated. But that's not the message we're trying to sending through right now. While you can want to know the advances in the treatment of endometrial cancer, when you Google it, when you find out there's so much information now, the penultimate and the bottom line is still finding it early, so to make the treatment as simple as possible and as inexpensive as possible. Nothing replaces early diagnosis for simplistic treatment of cancer. If we go into the advanced stages and intending to rely on targeted therapy, then we may be fooling ourselves because there are only a few, maybe 10 to 20% of patients who may be eligible for this so-called immunotherapy, which is very much the in thing now. People are always talking about PDL receptor blockade with pembrolizumab, talking about programmed cell death. It sounds very cool. People are talking about immunotherapy, sounds all very cool, but it's only available to a certain percentage of patients and not to everyone. So let's look at the treatment journey of an advanced cancer patient. We would wish that no one comes to this stage. If there is any early signs of uterine cancer, please seek medical attention. But this is a lady whom we would consider as someone who had unfortunately had this continuous uterine bleeding for a number of months. She had no medical or personal history or family history of cancer. She also was not taking any unopposed estrogen. But she thought she was perimenopausal and she'd been continuously bleeding for a couple of years. But it escalated to the point whereby she had sudden onset abdominal pain and she was eventually diagnosed with high-grade poorly differentiated endometrial carcinoma. She underwent full hysterectomy, surgery, The MSI, which is what we consider as a genetic test of the tumor, but she's not a genetic mutation carrier. She followed on with chemotherapy, radiation was completed, but unfortunately cancer recurred in the lymph nodes within a year of the completion of the surgery. Keytruda or pembrolizumab was commenced, and 4 years down the road, she has no disease recurrence, which is great. For an advanced cancer patient, sure, we have many ways that we can treat this cancer, but I would consider this lady as somewhat lucked out because she had this MSI unstable, which permitted her to use the immunotherapy. Assuming that she wasn't, there would have been no other choice but to have chemotherapy. But why suffer all this if we can find it early? So be aware of the signs and symptoms of endometrial cancer. What I want to go on a little bit more about is the nutritional and lifestyle changes that can alter our cancer risk. Looking at this right now, this is the metabolic syndrome and the BMI. The higher the BMI, the higher the risk of endometrial cancer is right at the top, followed by pancreatic cancer, followed by breast cancer, PM standing for postmenopausal. So for postmenopausal patients, if they do suffer from a rather large BMI or they have extreme obesity, their risk of getting postmenopausal breast cancer is high. Premenopausal breast cancer, fortunately, is less. So we can eat what we want and be physically inactive before we turn postmenopausal. But once we turn postmenopausal, we must be doubly active in order to reduce the risk of uterine, ovarian, and breast cancer. And this is to do with the advent of this thing called insulin hyperstimulation of cancer. If we have increase in energy intake, decrease in physical activity, in a high glycemic index diet, we end up increasing our insulin and increasing the risk of endometrial cancer. This is a very large study that was done recently and looked at the consumption of sugary food and drinks at the risk of endometrial cancer. Suffice to say that sugary drinks increases the risk with or without vitamin C. And unfortunately, fruit juices tends to be one of them. So one cannot be taking donuts, Danish pastry, cakes, sweet rolls, coffee cakes, cookies, ice cream, pumpkin pies, chocolate candies, candy bars, but they might be consuming canned foods, dry fruits, breakfast bars, granola bars, power bars, and cooked cereals, which are all considered as health because they are low fat. But low fat does not mean low sugar. Fruit juices are a very high chance and a very easy way of getting sugar just down very quickly. Yogurt, frozen yogurt, breads, jelly, jams, or syrup, and other condiments, including tomato ketchup. So the consumption of sugary foods and drinks can lead to the increase in endometrial cancer. What about the other things about meat? People always look at, oh, I don't want to eat meat, but I have to do my cakes. So actually, if we look at fish intake, this is what we call forest plots here. In the interest of time, I will be more than happy to share with anyone in this audience. If you'd like to contact Cancer Society, I'll be happy to share these slides with you. But suffice to say that fish is a plus minus, very balanced. So fish does not increase the chance of getting endometrial cancer. Thank goodness we know that, because otherwise we have no protein intake. Red meat, on the other hand, is a slightly increase in risk in some of the studies, meaning looking at people who eat a lot of red meat versus no red meat, there seems to be some increase. Poultry intake, white meat, less, meaning that we can eat chicken or white meat. Eggs intake and dairy intake, milk intake is also less. So this study has a take-home message to say that red meat versus a lot of red meat versus no red meat actually increases the risk of endometrial cancer, but we can stick to chicken, eggs, dairy, and fish. What about vegetables? Cruciferous vegetables, meaning caicin, broccoli, anything that is green, total leafy green vegetables, all reduces the chances of endometrial cancer. So anything green reduces, anything red meat, too much of it, will increase the risk of endometrial cancer. So looking at the diet-wise, the diet and endometrial cancer, the role of fruit and vegetable in the Mediterranean diet and dietary inflammatory index. Just now I said fruit juice was no good, but fruits in moderation is good. So when we take a high vegetable intake, a low to moderate fruit intake, and a low meat but high seafood diet, what we call a Mediterranean diet, focusing on good unsaturated oil, good sources of protein from the sea, and lots of vegetables, this can actually reduce our risk of endometrial cancer. But this takes years for us to build up. If I didn't eat this when I'm 15, I'm very unlikely to eat this when I'm 50. So there are ladies here you really need to work on your daughters and your children, because it's kind of too late for us to switch to this right at this point in time, because it'll take us 10 years to get used to this. Many patients I see only switch to this when they get diagnosed with uterine cancer or breast cancer. While we continue to encourage them to do so, the best time to do this will be when our kids are in their teenage years, so that by the time they're 40 or 50, this is just like second nature to them, rather than something they have to change. So dietary modifications, what about if they've already been diagnosed with endometrial cancer? Again, it's the same thing. We focus on the reduction of obesity, normalization of body mass index, reducing insulin that may result in reducing food craving and weight gain. There are even some studies to show that the popular but very difficult ketogenic diet and the new concept of ketotarian may actually reduce the risk of endometrial cancer and to treat endometrial cancer. Meta-analysis of 33 studies looking at highly physical active women have a 20% risk reduction compared to ladies with low physical activity. So suffice to say, we can't really reduce unless we're physically active and we reduce the fat intake and sugar intake in our diet. So there are still many randomized studies on the way focusing on physical activity and cancer, trying to answer these questions. What are the mechanisms at which physical activity can reduce cancer? How long and how often and how much do we have to train or be physically active? Is sedentary behavior associated with the increased risk of cancer, despite the fact that I'm very, very thin? Is it different for different ethnicity? Does it have to do with the genetic risk? So with that, I move on to a little bit of genetic testing before I go on to ovarian cancer. Looking at genetic testing, genetic test has been known to be, when we say about genetic tests, we think about family history. But actually, there are two types of genetic tests. There is a somatic mutation, which is lab-based, looking at the cancer per se. This cannot be inherited, but some of the somatic mutations can lead to the finding of a germline mutation, which can be inherited. So these are vice versa. If I do a somatic mutation genetic test on the tumor and I find a mutation that could be related to inheritance, I would recommend for a genetic testing for the family or for the patient themselves. Similarly, if I find a germline mutation that is inherited, I may be able to direct the treatments correctly to a patient. So in ovarian cancer and uterine cancer, I highlighted this to look at the hereditary breast and ovarian cancer syndrome and the Lynch syndrome. So this was the newspaper cutting from some years ago when we first gave the talk on genetic testing. Are we born to have cancer? Up to 5% of ladies in Singapore can be carrying this genetic mutation, BRCA mutation, Lynch syndrome, which confers them at a higher risk of getting cancer, but we can do something about it. So family history is the key tool. If there is a strong family history, unexpected disease at young age, associations that are rare and unusual manifestations, and these ladies will now be recommended to go through a formal family history and a genetic counseling in order to know if they need or they require to have a genetic testing. If they're found to be carriers of mutations, they can participate in aggressive screening or even benefit from intensive preventive surgery. So endometrial cancer, I just share a little, this is a very busy slide. Despite the fact that we have this considered condition called Lynch syndrome, which may be associated with endometrial cancer, it is only about 2 to 5%. Even if I am a carrier of a Lynch syndrome mutation, I can be counseled to have a low-fat nutrition and a low-carb nutrition, controlling my BMI, my risk of obesity, increasing my physical activity, to increase my chance of long-term survival, and also to reduce the risk of my getting the endometrial cancer. But ultimately, if I'm unable to undergo very, very strict surveillance, such as annual biopsy, transvaginal ultrasounds, or annual tumor markers, I may benefit from actually just going ahead and removing my ovaries, my uterus, and my colon when I turn of age, meaning when I've completed my family. These are the ways to reduce almost to 100% the chance of getting the cancer. What about invasive epithelial ovarian cancer? Again, looking at the increased risk, increased age, family history, above 50 years old, strong family history, these are the main two. But unfortunately, again, there are no screening techniques. We have to be aware of the symptoms: bloating, pelvic abdominal pain, difficulty eating, feeling full, urinary urgency, nausea, indigestion, gas, constipation, or diarrhea, extreme fatigue, and shortness of breath. The management, again, we need to see a doctor. If we're aware of these symptoms, see a doctor, get some blood tests for tumor markers, ultrasound, CT scans, followed by tissue diagnosis, followed by, of course, surgery, mainly also for histological confirmation. Fortunately, the majority of the ovarian cancers are very chemosensitive and still highly curable as long as we find them in the early stages. Unfortunately, majority of ovarian cancer patients benefit from chemotherapy. Looking at the timeline, again, we spent the last almost 60 to 70 years trying to find the best treatment for ovarian cancer. Nothing is compared to early diagnosis, being aware of the symptoms. When we have a late stage cancer, we can improve the chance of overall survival, but the chance of cure has been very tardy and very slow, mainly because it all is dependent on the tumor, the amount of tumor that we find in the patient when they first present. So let's look at the recovery journey of an ovarian cancer patient. Again, a 58-year-old lady, no family history, sudden onset abdominal pain, found to have large ascites, no ovarian tumor seen. The PET CT shows peritoneal cancer. She had chemotherapy upfront and was then found to have genetic mutation. She had chemotherapy followed by surgery, and she was recommended to have maintenance therapy, which she declined. And unfortunately, the cancer came back thereafter, and now she's on olaparib for treatment. The daughter is also found to have BRCA mutation, and she decided for removal of the fallopian tubes while retaining the ovaries and the uterus for childbirth. So I want to quickly just go into genetic mutation, because if we look at ovarian cancer, there was a question later on asking, what are my risks of getting ovarian cancer if I have a family history? Essentially, if I do have a family history of ovarian cancer or a personal history of ovarian cancer that warrants a detailed family history taking and potentially speaking to a genetic counselor or the gynecologist or a medical oncologist about genetic testing. BRCA1 and BRCA2, popularized by Angelina Jolie, increases the chance of ladies getting breast cancer or ovarian cancer or ovarian cancer. If you look at the graph on the right side, the risk can be up to 50% compared to 2% for a lady by the age of 50, and up to 87% of breast cancer by the age of 70 compared to 8% in the general population. But what is family history? Sometimes we say, my mother has this cancer, my father has this cancer, is it related? My grandfather had cancer at 80 years old, is it related? I had an aunt who was 79 who had breast cancer, an aunt that was 72 when she had ovarian cancer. Is it related? We are really looking for one side of the family. If it's both sides of the family, those are more likely to be sporadic and unrelated to genetic mutation. But if we look at one side of the family, two aunts and one uncle on the same side of the family, close family members getting cancer below the age of 60, that warrants certain detailed discussion. So overall cancer risk reduction surgery, why are we so interested in ovarian cancer, family history, and genetic mutation? Because the combination of risk reduction, oophorectomy, and mastectomy at the age of 40 years old can actually increase the chance of survival, meaning being cured from ovarian cancer in more than 90% of the time. Of course, if we don't want to go through risk reduction surgery, we can still go through the same nutritional counseling, low-fat nutrition, low-carb nutrition, physical activities to increase the chance of long-term survival. But suffice to say, because endometrial cancer and ovarian cancer does not have good screening techniques, we really have to be aware of the symptoms. But even then, majority of patients are found at a later stage for ovarian cancer. So if I am found to be a genetic mutation carrier, then risk reduction surgery, prophylactic surgery before cancer actually has a chance to set in is the best way of prevention. But many ladies don't want to come forward for testing because they think being a BRCA mutation carrier actually leads to me dying from cancer more likely. Actually, it's the other way around. Being a BRCA mutation carrier confers for a better survival for patients with ovarian cancer. So it's important to come forward and agree to have ovarian cancer genetic testing. But a lot of ladies don't want to do that. So I just show a case study of they're dealing with the emotional issues of familial cancer. Sometimes we seek a family and they're so used to the whole family having cancer that they do not want to do any preventative treatments. This is a 38-year-old with a very, very strong family history with 8 aunties and uncles. And out of which, of the 8 aunties and uncles, only one family doesn't have cancer. The rest, there is either colon cancer, ovarian, breast, or endometrial cancer in majority of the individuals in the family. Even her own sister has ovarian cancer. Mother is a survivor of breast cancer. She herself is a survivor of endometrial and colon cancer. She considered testing and she finally got testing, but there are many family members in this entire huge family who decline testing despite the fact that they are very likely to be positive. And their only excuse and their saying is, because everyone has cancer anyway and no one died from it, then there's no point of me getting tested because I'm going to get it anyway. So I think it's more of a fatalistic view on genetic testing. So I leave everyone here with some wise words. This was quoted by a cancer survivor. She said that it was fortunate that her cancer was discovered early. And she was fortunate that the cancer was what we consider as garden variety, common enough to have enough treatments that were available. So if we didn't know the signs and symptoms of ovarian, endometrial, cervical, breast cancer, we wouldn't know how to discover our cancer. If we knew that breast cancer can be prevented, ovarian cancer, endometrial cancer can be prevented by diet and lifestyle changes, why wouldn't we do that? If we knew that cervical cancer could be eliminated, why wouldn't we go for HPV vaccination? So if we cannot screen and we cannot prevent, we must try and find our cancer as early as possible. And Cancer Society has to make it easy for us to get this done in a very inexpensive way. We must also realize that these are common cancers. We're not talking about esoteric thyroid cancers, lymphomas. We're talking about the commonest cancer, which we know there are treatments available. So if we know that the cancer can be discovered early, we know that the cancer is common enough to have treatments that are available, and most of us have got good health insurances. If we, despite all these three, and we let the cancer grow and not treat it aggressively, it wouldn't make a difference. So the only way that we can make a difference is to pay attention to the top three, so that the truth is that we can survive cancer and live to a very ripe old age. With that, thank you very much.
Thank you, Dr. C. I hope you have get a chance to catch your breath. This is a very, very comprehensive presentation, information lots. And I think for the first time of all my years since 2008 that I've hosted a Singapore Cancer Society event, we have 108 questions in the Q&A, or 110 now, excluding those that were sent before the event started. We're actually, probably having like 130 questions. So I just want to caution everyone is that not all your questions will be answered. We will try our very best. Okay, let's do step by step. I think prevention is better than cure. We wanted to know that. I want to pull this to the three doctors here today. Is this, as a woman, and with the means and everything that these days we can go for screenings, etc., okay. And if you look into some of, and I think for Dr. C, the organization that you work for has a lot of executive screenings, etc. These are very generic things. What should we ask for as a woman, between the age of 25 to 45, where we are executives, we're entitled to a screening. What else should we add on to this, to increase our chances and live better? Because there's a lot of questions that ask, how come every time we find out it's so late, huh? Of course, there are a lot of denials and delays, but on a regular screening, what else should we add on to that?
Question to me?
I think it's a question to,
Yeah, okay. So I think the other my colleagues here would my colleagues here would agree with me that actually our executive screening is very much the same as what is available at the restructured hospitals. And executive screening is basically for women's cancer is all inclusive already. There's the mammogram, there are ultrasounds of the womb, the ovaries, the pap smear. This alone can prevent and can screen for 3 cancers. So it's already all very comprehensive. There are even tumor markers, which is potentially controversial. And I believe there was a question about a CA5.
Yes.
Yeah.
So the regular screenings, does it include the CA125?
Yes, it does. But I think Wylong might have some opinions about that, because CA125 can increase when during a normal menses or a lady with fibroids. So they may have no cancer whatsoever. So we really caution ladies who are premenopausal getting a asymptomatic CA125 testing, because it can lead to quite a bit of anxiety and over investigation. But for postmenopausal ladies, if they happen to go for a CA125 check and it happens to be high, then it can be potentially alarming. So it is the age. Younger ladies between 25 to 45, those with the means to go for testing, just be cautioned that if the CA125 is high, it does not mean that there is cancer. And this usually will be explained to by the physician who's doing the executive screening.
Dr. Wong?
Maybe I can jump in.
Yes.
Yeah. So I do see a lot of patients with health screening and a raised CA125, and that leads to a lot of anxiety for the women, especially those who do not have any ovarian cysts on their ultrasound pelvis. Now, we know even if you did have an ovarian cyst on the ultrasound pelvis and with a raised CA125 does not really necessarily mean that you have ovarian cancer. CA125 can be raised in a variety and many conditions, benign conditions or non-cancerous conditions such as fibroid, endometriosis. You took your blood test when you had your menses. You took your blood test when you had a fever. These can all raise your CA125. So, and CA125 can be normal in 50% of stage 1 ovarian cancer. So CA125 per se is not such a good indicator of whether this cyst is cancerous or not. I mean, we use CA125 to monitor recurrence, and I think that only if the cyst looks suspicious, then the clinician should order a CA125 to correlate with what are the chances of this cyst being malignant or cancerous. Yeah.
Dr. Tan, you want to add on anything on this one?
Yes, I'm not going to talk about CA125 because I'm not a gynecological surgeon. But I guess just to answer your question more specifically about screening, I think we have to understand why we screen for something. I think the criteria for screening is that number one, certain criteria among them are number one, the disease has to be a treatable disease. There's no point screening or something that's not treatable. And number two, usually for cancer specifically, so I'm not screening for cancers, not about heart disease and all that. For screening for cancers, you want a long latent precancerous period where there's a difference. So for example, breast cancer and colon cancer, there's a long period between it starting and it becoming symptomatic and killing someone. So you want something like that. If you have a cancer that has no treatment with a short latent period, then there's really no point screening. The screening, are there any dangers in screening? Some patients, I mean, I go and screen, right? So are there any dangers in screening? There are. The problem with screening is false positives, overdiagnosis and things like that. So I think I'm not discouraging screening. In fact, I'm encouraging screening. But I think what's more important is for any patient, not just women, but men as well, to discuss with the doctor, say for specific, say breast cancer, what's your actual risk of getting breast cancer? So I'll give you an example. If a 20-year-old woman goes to screen for breast cancer with no family history, it's really not good. It's really no point, because the chance of a 20-year-old woman with no family history getting breast cancer is less than 1%. It's highly unlikely. But then the harm of screening, if let's say they have a scan and they have a false positive, and then they go on to have subsequent tests and anxiety, and that's where the harm is. So I think it's about putting things in perspective. We screen for disease once we know your actual baseline risk of what it is. And of course, if you are a certain risk, average population risk, you follow the average population guidelines. If you're high risk, then you do it sooner or have different types of screening. Yeah.
I think I need to clarify, because I think from the layman and then the perspective of the doctors is a little different. For them is that I've gone to health screening to know that I'm in good health. All right. And we don't know.
Yeah.
And a lot of the screenings, or rather, the screening is not literally to prevent anything. It's basically to know I'm healthy, I'm unhealthy, I may have something that I needed to check on, or, it's like an insurance policy, just, I mean, if you say I'm a big kiasu and kiasi, so I decided to go for that. And the majority of them do that. I constantly have this argument with my GP is that I want to know if I'm menopausing. And she says, why do you bother? It will come. I says, the point is, I just want to make sure it is not something underlying. So I understand what you're saying. I think in most laymen, they look for that, is that they go to the doctor and says, let's do everything. You know, the company's going to pay for it. My insurance is going to pay for it. Somebody's going to pay for it. I'm happy to pay for it. I just want to do everything. Can we not do that? That means that's the question, that what else should we include? For example, if you do a mammogram and you don't do actually a CT, or sorry, an ultrasound, because sometimes after a mammogram, you still do the ultrasound in order to double check what's going on. And then likewise, you know, for screening the abdomen, you know, they use the ultrasound just to see whether the cervix, etc., or the uterus per se. So these are not usual prescribed screening methods. They only do that when they have to do that. But for someone who wants to know, I'm in the pink of health, I'm great, I'm really great, I have done everything, I've checked every single thing, you know, and not feel cheated when something happened, I'm actually at third stage, you know, why, you know? So that's the question. So what do you think should be included to the 3 doctors, that when I go for screening, I'm happy to pay for it, what should be included?
Can I just say something on that? Actually, to be very honest, we're talking about screening, right? Screening has a timeline to it. So it's a regular screening. I go for it once a year. You choose a date and then you go for it. Now, very often we see patients who actually already have symptoms of certain cancers. They will say, I go 2 months from now, can or not? I have an executive screening coming. I use that to help. That's not screening. That's called diagnosis. If I have a breast lump, it's not called screening. If I've got vaginal bleeding, it's not called screening anymore. But the screening is exactly that. If right now, if I wear red, my husband is upset with me, and I wear blue, my husband is happy with me, I will make sure that every day when I do a Zoom, when I take a photograph of myself, I'll be in a nice blue shirt, because my husband is happy with me because it's a blue shirt. So a screening is like that. I can be a pink of hell when I go for my screening, because that's usually what happens when people go for it. So the concept of screening has got to be explained in a layman's term. It is at that juncture a snapshot of what is happening in that person's body. But if I get screening in January 2019 and in December 2020, because of the COVID, I missed my screening, doesn't mean I won't have cancer. So people need to understand that when it comes down to screening, part of it is an opportunistic screening, is that the doctor has a chance to explain, oh, you know, you come for mammogram, you have this, so far it's okay, you need follow-up. But the converse is true. I ever took care of a patient who is not a patient. She's 25-year-old. Someone gave her a budget to go and get screened. So I want everything on the buffet list here, everything. So I cautioned her and I said, are you sure you want everything under the sun? We might find abnormalities for which then this is it, you know, it will be in your records. Next time you want to change insurance, you want anything, it's all pre-existing. She said, never mind, I want to do everything. And of course, Dr. Tan will be familiar, 25-year-old, ultrasound of the breast, what do we find? Many cysts and fibroadenomas. So that's it. She had to spend the rest of her next 10, 15 years checking for the ultrasound. But we can't find the breast lump. It's not physically examinable by the hand. So the question in the webinar was, why do we start only at 40 years old, 45 years old? Was because mammograms are only more accurate in the older generation. And in younger ladies, we have a higher risk of getting, what would mean that if I can feel the lump, I should go and see the doctor. It is more cost-effective use of this so-called screening than to say, I have no symptoms, I just go and do it every month. Then why not do it every 6 months? Why not do it every 3 months? I also have ladies who come and see us every 3 months religiously, getting scans after scans after scans after scans. And every time we see something in there, it doesn't stop. For the first 5 years, they'll be very diligent and very religious. For the next 5 years, they become almost almost worried and anxious every time. And until the point where I don't want to come and see you anymore, Dr. C, because every time I walk near your clinic, I feel very nauseated, you know. I feel like I'm so scared. But, you know, I didn't ask you to come every 3 months, but they build up to the point whereby the fear of the ultrasound before and after is so great that it becomes a very unpleasant experience for them. So I think you're right, is that it's difficult from the layman's point of view. I check one time forever, it would be great. This is the turnkey for me. But often than not, when we see breast cancer patients, cervical cancer patients, uterine ovarian cancer patients, we ask them, when was your last general checkup? 5 years ago, doc. 5 years, things change. So we have to be very aware of that. If we are committed to doing a regular screening, commit yourself to a regular screening. Don't just come like every other suka-suka to come. Then today I got problem, I don't come. Tomorrow I got no problem, then I come.
Thank you, Dr. C. That's the point. That's what we needed to drive back, because everybody felt so, So thank you very much. That was very detailed. We appreciate that. The other question is that, does breastfeeding actually reduce the chances of breast cancer?
Yes, it does. The evidence for it is actually quite long. I think the most often quoted studies done almost 20 years ago, and well published. And I think it shows that for every 12 months of breastfeeding, there's a 4.3% reduction in breast cancer chance, and that's in either totality for one child or for combination added up for different children. So the short answer to that is that yes, breastfeeding reduces the chance of breast cancer. And breastfeeding is good anyway for both mother and child, not just for breast cancer. So it's something that we should encourage.
So the question here is that if someone have already removed their uterus and ovaries, do they still need to go and get a pap smear?
If so maybe I could answer that.
Yes.
If you have removed your uterus and ovary and presumably your cervix, and for non-cancerous reasons, and providing that your last cervical screen is negative, you do not need to go for pap smears or vault smears, as we call it, because the cervix is no longer there. However, if you removed your uterus and cervix and the ovary for example, endometrial cancers or cervical cancers, then yes, we will screen or the recurrence using a vault smear. That means we will use a brush to just brush the ends of the vagina just to pick up some cells and see if there's any abnormal cells that can be picked up on the lab. And that's how we follow up for cancers of the cervix and the uterus.
Vaccine, the bivalent vaccine, if a child at 15 years old, a little girl, has already gotten that, and can she still go for the Gardasil vaccine?
Well, okay, so that's a very, very common question. My child has gone for the bivalent vaccine, and now there's a new vaccine out which has even better coverage. Should I go for that? The short answer is, I mean, it's good that you have already gone for the vaccination. That protects you at least 70% already. And not to forget that even after vaccination, you still need to go for screening. So I would caution against trying to chase the vaccine. Okay, there's a new one out, which confers 90% protection. If I go for that, and in the next 10 years, if there's another vaccine that comes out which confers a 95% protection, should I go for that? Then you start chasing the vaccination. So I caution against that. I mean, 70% is very good coverage. You still need to do your pap smears, whatever vaccination you take. So, you are already fairly well protected.
So the vaccine, someone should receive the vaccine before they are sexually active, or even after they are sexually active, they could still go for it?
So ideally, for the best protection, yes, you should receive the vaccine before you are sexually active, because that confers, I mean, if you're not sexually active, it's very unlikely that you will get HPV infection. Now, even if you were to be sexually active, you can still receive the vaccination, even if you tested positive for one of the HPV strains. There are so many other HPV strains that can be protected by vaccination alone. So, even if you are infected with one HPV strain, the vaccine does not treat that particular HPV strain which you are infected with. But it will protect you against having other HPV strains. It's really unlikely that you're going to be infected with all 4 or 9 HPV strains at the same time. So yes, it still confers protection. So even though you are, let's say there was a question here, even though I'm more than 30 years old, should I still get the vaccination? Yes, you should. In fact, you should. The vaccine is authorized to be used up to the age of 45. years old for females. Yeah.
So the question, sorry, I just wanted to finish the questions on HPV is that, can men be tested for HPV?
Well, certain groups of men can be tested for HPV, and the men that, is more likely to suffer from HPV related diseases are the homosexuals, so anal cancers is HPV driven. So yes, men of certain risk groups can be tested for HPV.
And do you encourage actually little boys receiving the HPV vaccines too?
Yes, that would be the ideal situation where all females and males are HPV vaccinated, and that confers herd immunity. So it will protect the whole society for the common good. Yeah. So boys should be, ideally vaccinated as well. Unfortunately, it's not really part of our vaccination schedule as yet.
But they do actually receive MediSave deductions too if the little boy receives vaccination, isn't it?
I don't
Only
think
little
so.
girls.
I think it's only for girls. Yeah.
Okay, thank you. We have a question here is on there's so many questions actually. The questions just keep jumping. We have 139 questions for the first time. I really don't know where to begin, but let's try. All right. If a report states that cervix adenocarcinoma gastric type while referral letter states is endometrial cancer, is cervical or endometrial cancer the same thing? It sounds like it is. Dr. C?
I'm sorry.
Dr.
Yeah. Okay. Dr. C.
Yeah.
Yes.
No, I think the question was that is cervical cancer with this adenocarcinoma, which is glassy type. So I think this was a referral letter. But if it was diagnosed via a pap smear, sometimes it's unclear whether it's a cervical cancer or an endometrial cancer. So basically, if the pap smear shows adenocarcinoma, sometimes it can be the endometrial cancer that is sort of dropping through and being diagnosed as that. So the treatment is the same in that we still need to consider surgery. So when she sees the specialist, the gynecologist will determine if this is primarily a cervical cancer, either through a colposcopy, or it is endometrial cancer, then a hysterectomy needs to be done. There's also this condition called endocervical carcinoma, which is a cervical cancer, but it's primarily adenocarcinoma, but it's at the lower part of the uterus. So it's considered as endocervical cervical cancer. So this lady's question is unfortunately not answerable on a webinar.
Thank you. The next question is that breast cyst or fibroid adenoma would it become breast cancer?
Okay, so breast cysts and fibroadenomas, simple fibroadenomas are a diagnosis that's usually made on either scans or biopsy. So I'm assuming we don't usually see patients come in and say I got a fibroadenoma. They usually have a lump. So, but if we talk about purely breast cysts and fibroadenoma, they do not become cancer. They don't change to become cancer. However, I need to cautiously say that if a woman have a breast lump, don't assume it's a fibroadenoma or breast cyst. Go see a doctor just to make sure of that. Yeah.
And would women with calcified breast lumps, in their breast, have higher chances of them becoming breast cancer?
No. The simple answer is no. Calcification, I tell my patients ask me what is calcification. Calcification happens in your body anytime as you age, and there are different patterns of calcification as that's seen on scans. The pattern, having calcification in your breast can be just part of normal aging. But sometimes when there's a small cancer, there's some calcification that sticks on top of the cancer, and the cancer can be so small that it's not seen, but when we do a mammogram, we can see that fine calcification, and that pattern suggests to us that there might be something hiding inside. Usually, it's not so much the calcification that we worry about; it's the pattern of it, what it looks like, that worries us. Yeah, that needs to be evaluated.
This question comes out every year. So, and it's the same thing with prostate cancer too, is that if people have never been sexually active, can they still get cervical cancer or uterine cancer or ovarian cancer?
So for true virgins, you should not, I mean, you would not get cervical cancer, but uterine or ovarian cancer is not related to sexual activity. So yes, you can still get ovarian or what you call it, and endometrial cancers without having sexual activity. Having said that, it doesn't really have to have penetrative intercourse to transmit HPV for cervical cancer. Heavy petting can also transmit HPV. So if true virgins should not actually have any HPV and hence should not get any cervical cancers. Yeah.
So does it mean that cervical cancer, the only cause of cervical cancer is because of HPV?
Majority so. More than 99% of cervical cancers are caused by HPV. I mean, very, very rarely do you get the non-HPV related cervical cancers. They do exist, but by far the majority of cervical cancers are HPV driven.
Okay, so there's a question here that asks, previously diagnosed with CIN2 and undergo LEAP to remove them, but 2 months after the procedure, pap smear still shows HPV infection. Why is that so?
So when you do a LEAP to remove the precancerous lesions, means that the HPV has already caused the cells of the cervix to undergo changes, and a LEAP just removes that that area of abnormality. And of course, when you do a LEAP, you will look at the histology or the report, to see whether the margins are clear. Now, after an excisional procedure as such to treat the underlying cervical or precancer changes, then we will do a test of cure. A test of cure essentially is a HPV test and a pap smear 6 months after the procedure and another 6 months after that. So a year from your procedure. Having a HPV test 2 months after a LEAP is a little bit early. Your HPV can still be there. It may take time for your HPV to clear by itself. So 2 months after a LEAP, it's a little bit early to do the HPV test of cure.
You mentioned in your presentation that there was sometimes HPV can cure by itself and just takes time. And you said within 2 years. And for someone that knows it and then there was no treatment, they were waiting for it to be naturally cured with their own immunology and things like that, then their own immunity. What should they do? Continue to have pap smear every 6 months just to ensure that it's cleared?
Oh, we do HPV tests every year. If you are HPV positive, we'll repeat the HPV test every year to check for clearance, and we will also do a pap smear, and you should ideally be followed up in a colposcopy clinic where we use a camera to have a look at the cervix to see if there's any precancerous change. So viral infection by HPV is just an infection. I mean, a big deal, but what really matters is this infection actually causing changes to the cells? There's nothing that we can do for the infection. There's no magic pill that we can take or any pill that can be inserted into the vagina to treat the infection. We can only treat the effects of the infection, which is this HPV infection or has this HPV infection caused cellular changes in the cells of the cervix that may warrant treatment or may progress to cervical cancer if untreated. So unfortunately, once the cells have changed its characteristics, then you can treat it. You can treat the cellular level, either cutting it out or burning it. But the HPV, it is still up to your own immunity to clear it. Now, young patients tend to clear it very easily because they have very good immunity. So a HPV infection in a young girl versus a lady who is postmenopausal, it's really unlikely that the HPV is going to clear on its own in the postmenopausal lady as compared to the young. So just like COVID, what's the situation now? For the patients in ICU or the patients who are mostly affected with COVID are the elderly or the immunocompromised who's unable to clear the virus on their own and hence causing lung problems.
Question is that, people with breast cancer, with cervical cancer, ovarian cancer, can they still go for the COVID vaccine?
I think I will take that question. So essentially, for the ministry is very clear right now, is that we want to ring fence our immunocompromised individuals. So it's not just ladies with active cancer, but it's also people with autoimmune conditions on immunosuppressive therapy. Suffice to say that anyone with active cancer, active cervical, uterine, breast, or ovarian cancer on chemotherapy or radiation therapy or oral medications that are chemotherapy and not anti-cancer hormones at this moment are not eligible for the COVID vaccine. That may change in the future when the majority of the population has been vaccinated and based on that time situation of the COVID. But for ladies who have completed their treatment, who no longer have active cancer, meaning in remission, or patients with early cancer that has been cured as long as 3 months beyond their chemoradiation, or ladies on anti-cancer hormone therapy, tamoxifen, letrozole, aromacin, anastrozole. These ladies are all eligible and fit for the COVID vaccination. So the word remission, they'll be asked 3 questions. Do I have active cancer? They are only having active cancer if they have just been diagnosed, just had surgery, and are on adjuvant chemotherapy or radiation. They also only have active cancer if they have cancer that is still under control, stage 4, or uncontrolled cancer still on chemotherapy. If they are not in either of that category, which means that they have inactive cancer, they may have had advanced cancer, but the cancer's gone, that's called in remission. But majority of ladies who have early cancers cannot use the word remission because their cancer has a very low risk of returning anyway. And then when they ask active treatment, it's only chemotherapy and radiation, not oral medications that don't cause any problems to the white cells. These people are all eligible for the COVID vaccination.
Thank you. Thank you. Thank you, Dr. C. To the doctors, what's your last parting word to our audience today? Dr. Tan?
Maybe I can start.
Yes, please do. I just
Okay,
thought
so
to do one round. Yes.
Okay. So for breast cancer, I think the most important thing is early detection saves lives. Breast cancer is so easy to treat these days at the early stage that when women come in at a very late stage, it's such a sad thing to see. Yeah, that's what I would say. My last words.
Thank you, Dr. Wong.
Okay, so mine is get vaccinated. I would restate what WHO has stated, that no woman should die from cervical cancer. So please get vaccinated, for HPV infection. Yeah, that's all I have to say.
And do their yearly pap smear, 25 to 29, pap smear every 3 years, 30 to 69.
3 years,
Yep.
Get
HPV
screened
every
for
5
cervical
years.
cancer as well, if you have it. That's right.
Thank you. Dr. C.
Up to 1 in 3 people in Singapore can get cancer. We need to know our cancer to prevent cancer.
Thank you very much. So, ladies and gentlemen, that we have today, we have Dr. Wong from the KK Women Hospital and Children Hospital, Dr. Tan Chuan Tian from the Ng Teng Fong General Hospital, and Dr. Si Hui Ti from Parkway Cancer Center. Thank you very much to the doctors, and we would like to end by saying is that no cancer to beat the cancer. So thank you for joining us. And with this QR code, please send us your feedback. Scan it, send us your feedback. Your feedback is important to us. And we would like to again thank all our doctors for this evening. And we thank our sponsors, AstraZeneca and MSD Singapore, for their support in this webinar. Thank you, everyone. Please show the QR code on the screen for a little longer for them to scan the QR code. Yes, thank you. And with that, we end this evening's No Cancer to Beat Cancer Women's Cancer webinar. Thank you, Dr. C. Thank you, Dr. Wong. Thank you, Dr. Tan. And thank you all for participating. Have a good evening. Thank you.